childhood, we used to throw stones to get marks. Most of us do it with the right hand. And we are excited when somebody does it with the left hand. Similarly, we all drive by sitting on the right side of the car. And when you go to another country, you have to sit on the opposite side. So it makes a lot of confusion. But there are world famous players who play with their left hand. So today, here, we have one important personality. I just want to know how many of you are left-handers, the students, among the student crowd. 1, 2, 3. Okay, 3. It's always difficult when we operate a patient and we adjust our position according to the type of surgery and the position of the organ. And I have not seen a surgeon operating with left hand. So that is something unique and so special. And here we have popularly known as SRD. I'm sure that everyone knows SRD. And it's a golden opportunity to see him in person. So that's why we thought we will introduce him to the students so that while they read the books, they will have the three-dimensional picture of SRD in their mind. And he was the head of the department of surgery at PMC Bangalore. So he did his MBBS and MS from KMC Bangalore, and he's the fellow of the Royal Brothers Surgeons of Glasgow. And you have SRB books, but he has written many other books also. One is SRB's Manual of Surgery, and SRB's Clinical Methods in Surgery, SRB's Text and Operation, that's a very big book. And SRB's Bedside Clinics in Surgery, SRB's Tissue Approximation Textbook with videos of different suturing techniques, and SRB Surgery for Dental Students, SRB Surgery for Nurses. And these are the books written by him, a dedicated teacher, well known among the students and the surgical crowd. I sincerely welcome him to address the students. Thank you.
Principal of this very famous college, good old college, Calicut Medical College, and HOD, dear Soman sir, my dear friend Professor Srijayan sir, and other faculties, of course, Dean SRMC, I thank him to be here to listen to me, Balaji sir, and other faculties, my dear students, undergraduates and postgraduates. This is not actually academic class, it's a insight probably what we are not, what we are to be. Unlike others, probably I don't think current generation students are bad. If there are few, they need to accelerate themselves and lead themselves into the current requirement. Meantime, what is clinical examination, good old, should be as a pillar for our eventual management of patients, which is going little in a different way. It's the only thing I want to highlight, so that you need to make use of these things, because most of the decisions, even now, we do based on our clinical setting, even post-op care, even decisions on table, even decision what surgery to do, everything. We have got images, MRI, CT, everything. Finally, you think, you analyze and decide, not based on always on images. This is what I just highlight. So this is what exactly can this be supplanted? Definitely my answer is no. And clinical exams, the millions worth. Imaging is needed. It is needed. It's often used. It is often abused. So don't abuse images. Just make use of it. What is as per need. So use imagination. What to do, what to take up, what type of images if you want to get all those things. So imagination is, it is surgery itself is imagination, it's not just cutting, remember. It requires a lot of thinking when you treat a patient. So all of you heard about this great man, Henry Waite. He was soldier and became surgeon in British Army, which is Scottish, and he was a scientist, renowned teacher also eventually. So he said, words are the greatest of all research laboratories, like Balaji Singh sir told, see patient, see patient, see patients. All of you know Robert Hutchison book is there. Currently they read or not, I'm not sure. But he is the one who coined in 1883 word clinical methods. I have read his first edition book, preface. Hereby I quote, word clinical methods should be used by all students who graduate from for medicine. This was he quoted in first preface. He quoted clinical methods. He said he said this is the foundation, this is the requirement. And Hamilton Bailey, all of you know, Bailey book is very popular. We got a beautiful another book he has written in 1935 before the rest book, clinical book, clinical demonstrations. It's a beautiful book. Old edition is very good. I have gone through entire book, 15th edition, current edition, lot of changes, 28th edition I think. So, you know, Hamilton Bailey had 4 fingers. He had his index finger he had lost because of some infective pathology. And so he used to have a separate specific 4-finger glove. So over that he has written a book, his clinical book, 100 years back near. That time colored photos, beautiful colored photos, illustrations, really remarkable book. So his wife was a photographer. So all those photos that time without any current technologies, he has taken photos and she has edited and put into the book. So that's what he has put in his preface. And I just go through the why this is clinical. This one is it's very important. It's what happened. We had a patient, a 59-year-old male, with all these complaints. I'm not going to detail. He had a lot. He had huge right some mass. He had gone to our specialty hospital, gone to the onco people, and I'm not blaming anybody. Definitely not. I'm just highlighting what is happening. And he had a mass, suspected and investigated, and ultrasound showed there is a mass in the right ilioinguinal region with the hypoechoic lesion, and suggested and the impression was soft tissue attenuation lesion, calcification, CT scan, and guided FNAC they would suggested that his impression was metastatic or poorly differentiated carcinoma, and CT guided biopsy features of metastatic adenocarcinoma. And what next? All these markers found normal, and colonoscopy and gastroscopy became normal. What next? By then it's a specialty hospital. Patient test went around more than 1 lakh, and he quietly slipped into our unit because it's a government setup. He came to our unit, and I examined myself and my assistant Sunil. We went to the examination room. We examined. I stripped him down. He didn't have right side scrotum is empty. Testis was not there. So we thought it is the testicular tumor. Clinically we thought it's a testicular tumor. So we had a good radiologist in Wenlock hospital. So we requested him. He said, did an ultrasound simply. He said it's mostly testicular tumor. Didn't do any other investigation. Thought it's not necessary. We explored. He had a testicular tumor and it was seminoma testis. Eventually all oncological, of course, further treatment is advised. So reason is we have not done the clinical exam. He said, I'm not questioning anybody. Patient said, sir, nobody has touched me. Like sir rightly told, nobody examined him, just touched this one. Nobody examined, everybody is busy ordering for CT scan, FNAC, this discussion. He said nobody has examined. Nobody is ready to listen to me. He said in his own word, local language. So this is the thing which we have to keep in mind. You listen to the patient. That's what sir rightly told. So there are so many other examples we see day to day. Tangulated hernia, they go to the medicine for gastroenteritis, they don't examine the groin region, then they go for sepsis, septicemia, shock, then it is referred to us. So we also do mistake if you don't examine, whether we are senior, junior, undergraduate, postgraduate, or anybody. If you don't do proper clinical examination, you will get troubled. That's the basic thing. I just want to pass on this message. Back pain, where patient repeatedly going to the orthopedician for back pain, and actually it is an aneurysm. It's very common. And bladder, distended bladder is mistaken for ovarian cyst. Somebody is about to operate distended bladder, thinking that ovarian cyst, pass the catheter on table. I heard really on table pass the catheter, mass is emptied. So such a simple thing, you should use brain, doesn't require any image as such. Rectum examination is very important. Even now, many times rectal carcinomas are missed because you don't do rectal examination. 90% of the carcinoma rectum will be clinically identified by rectal examination. And naturally, 90% of C rectum can be missed if you don't do rectal examination. So this is what, even these clinical methods are there since ancient era. They are not put the word in Greece. Hippocrates, all of you know that, we got votes. And he used to examine the patient, pulse, the temperature, palpation, everything. And same thing we have cultivated. All of you know that William Wassler described his quote, which is the father of modern medicine. So he who studies the medicine without book sails an uncharted sea, but he who studies medicine without patient does not go to sea at all. So all these things are clinically has a mystical power. Remember, your fingers are ultrasound, your fingers are images, your finger coordination from the finger to the brain. That's what you need to spend time. You need to stand beside the patient, like sir rightly told. Don't be in a hurry when you think about the patient, when you analyze about the patient. And definitely it is better than imaging. It's clear that history and skills will still remain at the very core of clinical practice. Remember, before imaging also, good old days, maybe 100 years back, clinical method, based on clinical methods only we used to diagnose cholecystitis, pancreatitis, malignancy, everything. By most of the time, because we had only X-rays. Of course, contrast X-rays come later, barium study, mainly barium study, X-rays. And based on that, then analyze, use brain. That's the only thing. So still it holds good. Even now, 80% of diagnosis, 80 to 90% are made by clinical method, remember. So what is the current scenario which has changed drastically? PG will tell, sir, ultrasound, patient has come, ultrasound shows gallstones, like that. Have you examined the patient? No, sir, this is this. I used to tell, examine the patient and come back. So you examine the patient. This is not just ultrasound. What exactly the patient is having? What are the symptoms? So what happens in deterioration in the physical examination skill? Increase blind faith in the technology. We believe technology. So we also started doing that. We just ask what is the ultrasound report? Have you advised a CT image, like that? Because it's available everywhere. It is a routine practice. And we don't have much time for meticulous clinical examination. So naturally, if you don't spend time, your relation with the patient will be lost, because they will be worried only you are asking for image, you are not speaking, you are not examining. Always, even once you admit a patient after examining the OP, again practice examine the patient again, touch the patient. If you don't touch the patient, just see images, they feel odd. He is not touching me, he's not looking at me. Look at him. That's very, very important. And diagnosis, you don't spend time at all. This is what exactly all these studies, they have done enough studies for that. So we don't spend much time. So clinical examination skills will gradually atrophy and become redundant if not rejuvenated and trusted upon. So who is going to regenerate? You have to guide them, and current generation students has to be rejuvenate. They are the future of this profession. They are the eventual pillar of this profession. Not we. I am at the age of 60. Maybe I will be able to work on for another 10 years. But you people are the pillar of this future healthcare system. So you need to cultivate these essential things, which is very crucial. And technology should become an extension of what you are doing rather than a replacement. Never replace. Take it as an extension, not as a replacement. understood. All these things are seeing, hearing, touching the patient, which we used to do. You know that is nothing but inspection, palpation, percussion. And are we thinking that old is gold? Not true. That's what is happening. We think what is old is not. You got no MRI, you got that one, you got PET CT. So everything PET CT. So PET CT has got a drawbacks also. So everything has got drawbacks, remember. So my apprehensive answer is really looks yes. We are not up to the clinical thing. And why this demise? You should have some reason for that. Why entire system has gone in a different direction, unlike what we are supposed to be. So there's increased workload of that. Naturally, there's less doctors. Most of the work done by the junior residents, postgraduate, most of the institutions, they are really working hard. 24 of their work, they are dedicated, but applications, directions are not there, and they are tired. Even consultants are tired because you are answerable for everybody. Patient party, politicians, media, everybody. We are scared. We are surrounded by everybody. That's why all this demise happened. Because finally, at the end of the day, we want to cover ourselves. So fear of subjective observation, lawsuits, all those things have changed our methodology and increased reliance on technology, reduced opportunity, bedside teaching. Again, we consultants blame ourselves as a teacher because we also don't spend much time with the students like what we were doing 20-25 years back, what I was doing teaching. Currently changed because students' approach is different, universities are different way, council is in different way. So we need to adjust for that rather than actuals. It is inevitable, even though we don't want compulsion for us to change our teaching method because of the current compulsive need. So net result is burning of the patient money naturally, losing our intellectual pressure, clinical discussion, clinical analysis, we are losing. Just to see the patient get an ultrasound image. We don't think what is anatomically, what is analytical, everything. Loss of trust towards the doctor. So what studies told in BMJ? So observe, deduct, clinical deduction, whatever it is, and knowledge, apply it. So it's what Sherlock Holmes, all of you know, these are the aphorisms by the Sherlock Holmes. All of you know that you see but you do not observe. See is not, the moment the patient comes inside, we immediately analyze the patient. What is his behavior? What is his body language? What is his face language? What is his eyes language? Moment, because we are trained last 35, 40 years, we are seeing patient. Moment somebody enters, anybody enters, immediately we'll have the idea about his body language, behavior, how is this fellow, what is the backup look. It looks immediately, you can make out. It's a disorder, we are trained. Immediately we'll mentally prepare how to speak this fellow. Individually we'll prepare mentally based on their body language. Remember, there's nothing like first-hand evidence. You need to put your hard efforts to this one. So observe. So finally, sir rightly told, human touch. So without that, you won't be able to manage patient. It is not technology always. It is human touch. That is the most essential thing, because they are ill, like sir told. They are ill, that's why they are coming to others. They won't come to you. So need to have some empathy to them. So human touch is very important. And building trust to the patient by this. And we've got so many roles. I'm not to advisory role. They expect you to advise what to do, what not to do, all those things. They expect you to tell the therapeutic role also, what treatment, what, all those trial and error things. They will discuss with you once you trust you people. So history is a very important thing. Wealth of information you can, so sit with the patient. That's what William Wassler told. Always listen to the patient. They might be telling you the diagnosis. That is very important. History tells us, duration is important. What other history, additional history is important. Because without that, you won't be able to come into conclusion. Remember, learn to observe. That is what examination is important. So learn to observe everything, head to toe. Learn to observe in a patient. So learning ladder is, there's a deep learning. You can see that to reach top is not that easy in our profession. It's a repetition. Clinical examination, documentation is currently very important. If you protect you legally, and if you habituate that, you remember, you can always go through that, what you have written, what is exactly patient is having, analysis, understanding images and evaluation methods. Now learning, how to learn, 25% you can learn from the teachers, 25% by your own effort, 50% by repetitive methods. See patient, go to the hospital. That's what That's what is told, that wards are the greatest laboratories. So if you are a clinician, you need to be there in the hospital. You need to be there in the wards. So there's no other way. You can't learn. We can't learn these things, unlike in engineering field, online. We can't learn these things by sitting at home or street. You need to be there inside the hospital. Important. Remember, and learn what is essential. There is this one. This is what I am going to learn. This is important. Learn what is important. Learn what is helpful. And learning is not one day match. Remember, not even definitely not T20 match. It's a test series. It is an ongoing phenomenon. It takes time. Learn to ask why. That's very important. Why it is so? Why not? These things are important because we have been asking when we are trained our professors why it is tell, and why if you say something it's a why not they will ask. So next question is why not. So you should be prepared for such questions. Learn also when to do and when not to do. That's important. It's not every patient who do surgery. All surgical patients don't require surgery. So you need to take a call when to do, whether to do surgery or not one, when to do or not. So timing, everything that's no image will tell. It's your clinical sense. It's a common sense application. You are answerable for every word you speak and every act you do. Remember, you are a professional person. You can't have a casual word or loose words with the patient or anybody. You need to have a clear idea about what you are speaking. So your every word is accounted and counted. Remember. And clinical diagnosis, anatomical, pathological, all of you know that, anatomy inspection, I'm not going to detail that. Observe small things and everything. Everything is small thing. That's a small thing. Observe everything, observe small thing also. Because every information is very crucial to have a conclusion. Remember, proper documentation currently is very important. All of you know, ethically, research is upcoming now. Everywhere research. Institution is very particular about that. To document, now we got enough technical support for that to document. Unlike olden days, you have to write everything, keep file, then you have to search, you have to document it, label it, where is that file. Although now we got a system, computer, everything. It's easier rather than what we struggled in olden days.
Confidence. I know surgery. I know principles. I know how to do tap, basic levels of the surgery. I only know surgery. Others don't know surgery. I'm the only person treating all patients. Only my surgeries are best. Only my surgeries do the results. That is what ego. Ego is really dangerous in medical profession. But in the meantime, don't be less confident. Have a confident. I can do. I can treat. I put my hard work and treat this patient. I will learn from somebody and come up. That is confident. I did confident, but never be egoistic. That is definitely dangerous to surgical profession. Remember, be have a confidence, but leave your ego. That's most important thing. And there are three things that are very important in human life. Need, all of you know that any individual in the system, they need food, they need shelter, they need basic food, cover, shelter, food. Anybody, any human, poor, rich, that is accepted. Desire, yes, I wanted to become like my father was teacher. I wanted to become a doctor. I wanted to become a surgeon. I have written few books. Yeah, that is the desire. Definitely accepted in the society. Greed is the dangerous thing. Should never be greed. Everything should doctor. I am everything. Not at all. I will eat. Definitely project your desire and read the darkness, but avoid the greed. That is dangerous to you, dangerous to the society as such. Remember. And contentment. I have done this much. I'm doing few laparoscopy surgery. I got a good practice. I have become HOD. I have written few books. I'm happy with that. Till I want to become, I can't be like Honorary definitely. I definitely respect him, but I'm happy with what I'm having. Contentment is very important. Remember, what you are having, you should be happy with that. God has given that. Humility. When you are grown up, you should have a humility. That is the essential source for human life. And going to achievement, it comes on a spot, remember. And in this bright future, you can't forget your past. You have to be someone that is there. That is a wish from your parents, from your family. So work for that and beware. Common sense in medical matters is bad. And it's usually in inverse ratio to the degree of education. It is not my work. It's on the great person, William Oscar. He put his first word under quotation, what it should be common sense, this very essential thing. 100 years back, he said that still true, even now. And finally, collect the facts from history and clinical economics before arriving at the diagnosis. Hello, anatomy and common sense to guide you to the diagnosis. Anatomy, through clinical acquisition that guides you to whatever required thing for the patient. And you're on the way, but far from the perfect. Nobody can be perfect in this system. Everybody has got a likeness. Everybody has a shortcoming. You have to correct it, whatever reasonable extent. Of course, in medical profession, see what exactly often to the clinician. Patient related is questioning, media is questioning, consumer law is questioning. Again, NNC, MCA guidelines, sir knows how difficult it is to factor. Universities, regulations, you are bound with so many things. No other profession is bound so much with these regulations and problems. Still, we can sin through this if you want to have a good relation, like irrespective of the caste, age, race, country, state, whatever it is. Be a good doctor, be a good human being. Wherever you are, with a relation like dog and cat we are playing, why can't we human beings be together? Honestly, work for the development of nation, world as such. Thank you, Procedure, sir, for giving me opportunity and sir, and thank you very much.